on your Saturday night, giving up all the fun stuff to study so you can pass NCLEX, right? Or learn as much as you can. I was going to give it a minute or two to see if anybody else was going to join, because it's just 6 o'clock. All right, well, welcome to the webinar. Thank you all for joining me, like I said, on this Saturday evening. A quick shout out to the technical team that helps make this a seamless process. Also to my co-pilot that will be answering questions in the chat, or any questions that you have, go ahead and put them in there. Feel free to unmute and answer also. I do want to let you know that the presentation will be available to you after the presentation is done. You can go onto our website at any time and click on the previous webinars and see any of the webinars that have been done. And going forward, anything that's done, once it's completed, it will populate there and you'll have access to it. So back to my thank you for my co-pilot to being here and answering questions in the chat. Again, feel free to unmute and ask questions if you would like to. I appreciate you engaging and I love to hear what you're all thinking. Has anybody been doing the practice questions? I wondered how they were going. Feel free to unmute and answer if you are willing to. And welcome in to anybody who just joined us. Looks like we have a couple people who just joined. Is anybody scheduled for their NCLEX test yet? Are there any dates coming up soon? I'll take a quick peek in the chat. Yes, yes, and yes. In a month? All right. Karine, I think that says in 1 month. Great, great. You have lots of time here then to get through all the webinars and practice, practice, practice. Next month, great. Okay. Well, oh, in 2 weeks, Ruben, Kim, 2 weeks. All right, well, good luck to you guys and girls in 2 weeks. I'll be thinking about you. All right, I'm going to go ahead and get started. I'm scared. Well, you know what? You got this far. I'm going to restate the things I always state at the end of my presentations is you've already graduated from school. You're all smart. You all made it here for a reason. So have confidence in yourself. That is the best thing you can do, and practice, 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 and you will do just fine. All right, and you're working full time. I know, you know, the best part about working in a hospital, even if it's full time, is that you get exposure to things that will be on your test and will definitely be part of your future in your practice and growing your practice or growing your craft, however you want to look at it. But you are subconsciously remembering things and connecting dots to things that you maybe don't even realize. So I know it's hard to work full time and take your boards. I did it. I understand it. But I can tell you what, you're learning a whole lot. So keep doing it. And it looks like somebody's doing really well in practice. Keep doing those practice tests. That's a really good score. So keep it up. Keep it up. All right, guys, we have a lot today to get through. And they're going to be doing some stuff on the website. So we're going to try to get through this in about an hour and a half today. And I want to make sure that we have enough time at the end for going through questions and devoting the time that they deserve. So I'm going to get going. This presentation aims to provide an in-depth understanding of the key concepts of complex respiratory problems or issues, including their definitions, their types, their treatment modalities, and practical strategies for taking exams like your NCLEX in 2 weeks or in a couple of months or in a month. We'll cover everything from oxygen delivery today to mechanical ventilation. You can see we've got a jam-packed agenda once again. We'll begin with an overview of complex respiratory problems, followed by discussing supplemental oxygen, non-invasive ventilation techniques, intubation methods, and mechanical ventilation. Finally, we'll explore the effective strategies for succeeding on your NCLEX, and then practice some questions, which I am sure you guys are all going to do very well at. Complex respiratory problems encompass a range of conditions that significantly impact breathing and gas exchange, and will probably be a high population of your patients in your practice. Respiratory problems can be classified into obstructive, restrictive, and central causes. This classification helps in the diagnosis and the treatment of the conditions like asthma, COPD, and pulmonary fibrosis. These are not an inclusive list. There are so many different types of respiratory conditions. For example, bronchitis, lung cancers, cystic fibrosis, interstitial lung disease, pulmonary fibrosis, pulmonary hypertension, RSV, TB, obstructive sleep apnea. There's lots of different respiratory illnesses and respiratory problems. You'll note on my slides in this presentation, there are things that are highlighted in yellow. Those are things that I think are important for you to pay close attention to. I think they are things that may come up not only in testing, but definitely in your practice. So stay familiar with those things, and you'll see that throughout this presentation. So again, anything in yellow is yellow for a reason, so pay attention to that. Obstructive respiratory problems involve difficulty in exhaling air from the lungs, commonly seen in conditions like asthma and COPD. COPD affects more than 480 million people in the world. It's the #1 leading cause of death related to respiratory illness. Restrictive respiratory problems are characterized by reduced lung volume, making it difficult to fully expand your lungs, commonly seen in pulmonary fibrosis, asbestosis, and sarcoidosis. Central respiratory problems are those that are caused by issues in the brain affecting the respiratory muscles, leading to inadequate breathing. Congenital conditions like hypoventilation, brain tumors, encephalitis, and spinal cord injuries are examples of those. Patients with respiratory issues may exhibit symptoms such as shortness of breath, wheezing, and cough. Now, we all know those are symptoms of a lot of different illnesses, so let's try to think about things that are specifically related to those types of illnesses. Tie them into something to give yourself a picture of what it's going to look like when you take care of your patients. And if anybody's worked on the medical unit or taking care of patients with respiratory illness, you can sort of connect the dots or think about what kind of patients you've taken care of and what their symptoms were and what you did to treat them or the interventions that you provided to sort of give yourself a picture on breaking it down. Okay, so patients with respiratory symptoms, like I said, exhibit shortness of breath, wheezing, and cough. A thorough assessment, including the history taking and physical assessment, are necessary for the appropriate diagnosis. And that is because so many of the symptoms are similar in different respiratory illnesses. So symptoms of respiratory issues, like I've already said, I think twice: shortness of breath, wheezing, and persistent cough. Importance of assessment. Accurate diagnosis of respiratory issues is necessary to determine the appropriate treatments. One of the ways that we do that is by history taking. Gather a detailed medical history, which is crucial to understanding the condition and the patient's symptoms. Chronic obstructive pulmonary disease, or COPD, refers to a group of conditions, primarily emphysema and chronic bronchitis, which cause airflow obstruction, hence the word obstructive in the word chronic obstructive pulmonary disease. Patients experience symptoms such as chronic cough, wheezing, and shortness of breath. there's those three symptoms again. Key treatments include bronchodilators, corticosteroids. And what do the corticosteroids do? They reduce that inflammation and improve airflow. Nurses play a crucial role in monitoring respiratory function and providing education on lifestyle changes, particularly smoking cessation in people who have chronic obstructive pulmonary disease. Asthma. Asthma is a chronic respiratory condition that causes inflammation and narrowing of the airways. Patients may experience symptoms like coughing, wheezing, chest tightness, often exacerbated by allergens and irritants. Effective management involves the use, again, of bronchodilators and corticosteroids. Nurses are essential in educating patients about this condition, developing asthma action plans, and promoting adherence to their medication regime. Of note, it is important when teaching somebody about their asthma medications to talk to them specifically about their rescue inhalers in emergency situations. Pulmonary fibrosis is a very serious lung condition that results in the scarring, hence the word fibrosis, of the lungs, making it progressively harder to breathe. Patients typically present with a persistent dry cough and an increasing shortness of breath. Treatment may involve medications like peripherin and nintedanib to slow disease progression and supplemental oxygen for comfort. Those two medications are called antifibrotic medications, and I'm sure I mutilated how you say them, so I apologize for that. But they are used to slow the progression, and supplemental oxygen is the other thing we use for comfort. Nurses play a significant role in monitoring respiratory status and providing emotional and psychological support, especially to these patients, because it is progressive. Spinal cord injuries result from trauma that disrupts the normal functioning of the spinal cord. Depending on the location and severity of the injury, patients may experience partial or complete loss of movement and sensation. Injuries with a C1 to C2 injury involvement result in diaphragm paralysis and phrenic nerve injury, which will require mechanical ventilation. Injuries that involve C3 to C4 involvement may require ventilator support but may improve with rehab. Treatment focuses on rehab to maximize recovery and independence. Everybody thinks Superman here. He had a C1 to C2 injury, spinal cord injury, and was on mechanical ventilation for the rest of his life. There are treatment options such as a stimulator for the phrenic nerve that cause the diaphragm to contract, and in rehab it helps improve the respiratory muscles, which may help in potential possibility of weaning these patients. Spinal cord injury patients with respiratory complications such as mechanical ventilation have a very high incidence of mortality, and I bet you can guess why. Complications like pneumonia and atelectasis are very common. Consider this. You have a patient who has asthma or COPD, and they are smoking and have smoking damage prior to their injury. And now they have a spinal cord injury and require some sort of, whether it be C1, C2, or C3, or C4 injury. They have those comorbid conditions on top of a now spinal cord injury, which affects their lungs. You can see how the mortality could be quite significant, or just how difficult it could be to get somebody off of a ventilator. Various factors contribute to respiratory problems, including smoking, environmental and occupational pollutants, infections, and genetic predispositions. Farmers and military personnel, along with minors, have the highest risk of occupational lung disease. Exposure to radon, asbestos, coal dust, and fungal spores, along with animal droppings, secondhand smoke, and air pollution are all examples of hazardous substances. Supplemental oxygen is critical for patients with respiratory distress. It's important to be aware of the various delivery systems available. There's some yellow on this slide. Oxygen delivery systems range from low flow devices like nasal cannulas to high flow devices such as non-rebreather masks. Each system has specific indications based on the patient's needs. Low flow cannulas and high flow differ in the amount of oxygen that they can each deliver per minute. Additionally, high flow is delivered as warm oxygen due to the rate being so high and drying out the nasal passages, which can quickly result in nosebleeds. Low flow cannulas can deliver approximately 6 liters of oxygen or up to 6 liters of oxygen, but it is not warmed. And the high flow can deliver up to 60 liters of oxygen. I want to focus in on this just to kind of reiterate. Low flow devices such as nasal cannulas provide supplemental oxygen at lower rates, suitable for stable patients, and can deliver up to 6 liters a minute of oxygen unwarmed. You're probably very familiar with that. And then high flow devices like a non-rebreather mask deliver at higher rates, suitable for patients requiring increased oxygen support, and they can be delivered up to 60 liters of warmed oxygen per minute. Each oxygen delivery system has its benefits and its drawbacks. For
I'm
instance,
so sorry. Can I have a question?
Sorry. Go ahead.
That means when we have a high oxygen, that one is only indication when we have a carbon
Can you say that again?
monoxide poisoning, ICU, CCU department. I said when we have a high one, yeah, high oxygen supplement, it will be with the carbon monoxide poisoning, ICU, CCU patient, yeah, usually.
Yes, yes. And actually, I talk about it a little bit later, but not only
Okay.
It's definitely in critical care that they use the high flow.
Okay, thank you. Okay, sorry, I don't know you will talk. Okay, thank you.
Oh, no, that's okay. Please feel free. I want you to engage and share what you know, because you guys are out practicing and you're seeing things and we all learn from each other. So it's really important to do that. So thank you very much for doing so. And please don't feel like anybody has to apologize for speaking up. I want to hear from you, and everybody on the webinar wants to hear from you. Again, sharing is caring. We learn from each other, right? All right. Each oxygen delivery system has its benefits and drawbacks. For instance, nasal cannulas are comfortable, but may not provide the sufficient oxygen. Those requiring high flow oxygen may need something other than a home setting. A lot of times people who are on high flow oxygen cannot go home. They may need to go to like a long-term acute care. Some nursing homes I know here do have the potential for high flow oxygen, but some also do not have. So these patients may not be able to go right home from the hospital if they need the high flow oxygen. Now, low flow, we can do condensers at home, and they typically are able to go home if they only require the low flow cannulas for oxygen use. Just like to throw that out there because it is something that does change the discharge planning, and it certainly does change our efforts in trying to get people off of high flow to get them to a place like home upon discharge. Oxygen tanks, oh wait, I forgot to mention, which you probably are all very familiar with, but it's also imperative for nursing education to include information regarding oxygen being flammable. Smoking cessation should be addressed. Oxygen tanks and condensers are flammable and should not be near any source of heat. Additionally, condensers do require electricity, so there may need to be some consideration for optimal placement in someone's home. It's also necessary to provide clear information on where patients are supposed to call if they need assistance with their condensers or their home oxygen, or if they need more oxygen delivered. We never want to send somebody home with their home oxygen and they do not know who to call in case they have questions or problems. Even if they're not emergencies, we want to make sure that they know who it is they're supposed to contact. Nursing education should also include education on signs and symptoms to call their doctor. For example, fever, shortness of breath, on the O2 with shortness of breath, pale or blue lips, changes in their breathing, increase in the labor it takes to take a breath, nasal flaring, wheezing, grunting, or a noisy breathing. Sometimes they don't know what the terms are that we know, so you might have to describe it more like the noisy breathing as opposed to referring to it as like grunting. So that they know, geez, it takes a lot more for me to take a breath. Oh, maybe, maybe I'm just getting used to my oxygen. Well, no, you should probably be calling your doctor and letting them know, because that could be indicating that there's either further problems or maybe we need to increase your oxygen. When using oxygen delivery systems, it is vital to consider patient-specific factors, including their respiratory status, oxygen requirements, and where those things can be managed. Risks associated with oxygen use include lung damage or pulmonary toxicity. Another consideration is the risks associated with smoking and the flammability of oxygen. I should have probably added to this slide, when patients have symptoms or once they get home and they feel like they're feeling better, sometimes they'll turn off their oxygen and decide that they don't need it. Or maybe the reverse is true and they'll say, geez, I just need a little bit more, and they turn up the dial a little bit. So it's important to make sure that they know that it is a prescription of the oxygen that they're on, and they should not be adjusting that medication. They should be leaving it at what the physician prescribed them to be on when they were discharged. Just some more nursing information. All right. Non-invasive ventilation is an effective treatment for patients with respiratory failure. We'll explore the mechanisms and applications of CPAP and BiPAP. CPAP, continuous passive airway pressure, or CPAP, provides continuous airflow to keep airways open, which is beneficial for conditions like obstructive sleep apnea. It enhances oxygenation and reduces the work of breathing. It can improve your sleep. It can improve your sleep quality. It can improve or reduce snoring. So it can make your partner sleep better too, because they're not keeping you up. You're not keeping them up at night with your snoring. It can improve a feeling of daytime fatigue. Typically, people who have sleep apnea have this daytime fatigue and they're feeling tired all the time. Additionally, long-term benefits of usage of CPAP can help control or prevent hypertension. It can reduce stroke risk, and it can improve memory as well as cognitive function. Side effects can include nosebleeds, dry mouth, and difficulty to get used to. The nursing interventions are to encourage regular use of their CPAP. I know patients will say, oh yeah, I have a CPAP at home, but I don't use it. Exploring why they don't use it, and if it's the mask or if they have the nasal pillows, or maybe it doesn't fit right, or they just forgot to replace the equipment, so now they don't use it. Explore why they're not using it, because it is really important. And a lot of times the issues that they're having can be rectified or improved to make them much more compliant with their CPAP. So nursing intervention should encourage the regular use of their CPAP, encourage patients to report any kind of problems or concerns, again, because a lot of different equipment options are available out there now. And so getting them to be more compliant is much easier than it used to be. CPAP does not deliver oxygen, However, it can be added as a separate treatment in conjunction with CPAP in certain conditions. So I just want to reiterate on this slide, I have a little yellow. CPAP delivers continuous airflow to maintain open airways, especially beneficial for patients with sleep apnea. CPAP enhances the oxygenation of the blood, improving overall health and sleep quality, as well as many cognitive improvement. CPAP reduces the effort needed to breathe. BiPAP, which is bi-level airway pressure, bi meaning two, delivers two levels of pressure, higher during inhalation and lower during exhalation. This can help patients who have difficulty with CPAP alone, particularly in exacerbations of COPD. It is often used in more critical and severe respiratory situations, such as sleep apnea with severe airflow obstruction, heart failure with respiratory distress, and as stated, COPD exacerbations. BiPAP can be customized with different settings also if needed. BiPAP provides two distinct pressure levels, very important. BiPAP is particularly beneficial for patients with COPD, which improves their ease of breathing during respiratory or episodes of exacerbation. BiPAP adjusts pressures to meet inhalation and exhalation needs. A lot of times they will try to put patients, maybe patients that are sort of on the downward spiral, they'll try putting patients before they have to go to mechanical ventilation. They will try BiPAP to see if they can get the patients to turn around before they have to intubate and put them on mechanical ventilation. I do see a lot of this in the intensive care unit, although they do use BiPAP in like LTACs, long-term acute care settings as well. So just something to mention. I can't say that I've seen them used on the medical floor, but typically in the critical care unit and, like I said, long-term acute care. Has anybody out there working in the hospital seen BiPAPs used on the medical floor? If so, go ahead and speak up while I move on. Okay, this is kind of a comparison, CPAP versus BiPAP. Some key differences. CPAP provides constant airflow. BiPAP offers two pressure settings, higher on inhalation, lower on exhalation. BiPAP is often more comfortable for patients with COPD. CPAP is primarily used for obstructive sleep apnea treatment. BiPAP assists in both inhalation and exhalation for better breathing. Adjustable pressures in BiPAP accommodate varying patient needs. I am going to, before I move on, I'm just going to go ahead and take a quick peek at the chat to see if there's anything that I need to respond to. Yeah, I see you're talking about the percentage on the test. Maybe, I do believe it should be over, I want to say 70 or 80 in order on the readiness test to see if you're ready to take your exam. So that's sort of what I have read and what I have heard. So somewhere in the 70 to 80 range. So you guys are doing great. You said flow oxygen can cause. Actually, I think that high flow oxygen can cause, I don't think I said carbon monoxide. And if I did, I didn't mean to say that. Most ICU and CC, yes, I agree. Critical care unit and intensive care unit. And I'm not sure about step down, or I think the step down definition varies based on hospital. So I would say probably just critical care and ICU. If Fermones could answer that question, can you please check on high flow oxygen and ask about carbon monoxide poisoning and see if they are a side effect or if that does happen with the high flow? It can definitely damage the lungs because of the high pressure or the high flow of oxygen that happens in high flow. It also can cause like a fibrosis, so something to just put out there. But if Monies wouldn't mind checking on that and maybe putting it in the chat, that would be great. Okay. All right, so we finished the compare and contrast slide. I just want to see if there's anything else that I wanted to share with you. CPAP is reported to be more comfortable by patients, with the exception of COPD patients. That's why I put this on here, because it's kind of interesting that BiPAP is often found more comfortable with patients with COPD. I'm sure it has something to do with the fact that there's 2 levels and you can adjust the pressures on inhalation and exhalation, where you can't do that on a CPAP. It's just that pressure of airflow on inhalation. All right. And I just found that to be an interesting piece of information. So when you're caring for your patients, you might hear that and be surprised. Okay, clinical indications and benefits. Indications for non-invasive ventilation include acute respiratory failure, COPD exacerbations, and pulmonary edema. Benefits include improved oxygen and a reduced need for intubation. The non-invasive ventilation, I did say acute respiratory failure. Those are the patients I was referring to earlier that are sort of in the downward spiral, and they're trying really hard not to have to intubate and do mechanical ventilation. It sometimes does end up that way, but a lot of times they will start with the BiPAP, if it's possible, obviously, to turn the patient around. Non-invasive ventilation significantly reduces the need for intubation, providing a less invasive option for patient care. Unfortunately, some of those patients still end up requiring mechanical ventilation, but it certainly does reduce the number. Intubation is a critical procedure for managing severe respiratory conditions. Understanding when and how to intubate is essential for healthcare professionals. Indications for intubation include inability to maintain airway patency, severe respiratory distress, and protective reflexes. Recognizing these signs is crucial. It's supposed to be loss of protective reflexes. I knew that didn't sound right when I said it. Loss of protective reflexes such as the gag reflex. Indications include ventilation where patient is unconscious or in a state of apnea, airway protection such as aspiration into the lungs of gastric contents to prevent further aspiration, especially when the gag reflex and the cough reflex are not present. And the number one reason we intubate patients, as everybody know, is because of providing anesthesia. General anesthesia during procedures, which is the most common reason we do use mechanical ventilation. Inability, okay, airway patency issues, inability to maintain airway patency is a primary indication for intubation. It is yellow. Hopefully you can see that on your slide. Severe respiratory distress can indicate the need for intubation to ensure adequate oxygenation and ventilation, and the loss of protective reflexes such as the gag reflex. Those are all yellow, so I thought they were important, and that's why I wanted to highlight them again before we moved on to the next slide. The endotracheal tube is used to secure the airway during intubation. Understanding its components and placement techniques is vital for success in intubation. Okay, this one's all yellow. Both orotracheal and nasotracheal intubation techniques have specific indications. Oral tracheal intubation is preferred for emergency situations or emergency scenarios where rapid airway access is necessary. It is also sometimes used in, nasotracheal may be used in elective cases. Examples of nasal intubations include obstructing oral mass or oral surgery, fractured mandible when you can't open your mouth, neck injury, and an awake intubation. A lot of times they'll do a nasal tracheal intubation if the patient's awake. And somebody who's going to be on intubation for a long period of time, nasal intubation is tolerated better by patients. So that's why they would typically use the nasotracheal intubation over the oral tracheal intubation. Mechanical ventilation. Mechanical ventilation may be necessary for patients with severe respiratory failure. For example, when patients cannot breathe on their own, it is life support. Ventilators keep airways open, deliver oxygen to your lungs, and remove carbon dioxide. Think of it as crutches for your lungs. Settings can be adjusted as patient needs more or less assistance with breathing. Understanding its principles and applications is key for effective management. Intubation and ventilation are not the same thing. They usually go hand in hand, but they are different. Intubation is the tube placed down the trachea and connected to the ventilator to provide the mechanical ventilation. Of note, a tracheostomy in the neck can also be done instead of the tube being placed down the trachea due to obstruction or because of other situations. It's usually about 2 weeks of somebody being intubated before they look at the possibility of doing a tracheostomy for a patient on mechanical vent with intubation. Long-term ventilator support is usually provided this way. Again, think Superman. If you have a patient who is likely going to require long-term mechanical ventilation, after about 2 weeks, they're going to start looking at doing a tracheostomy. Sometimes it's give or take. If they expect the patient to come off fairly quickly, they may not advance to the tracheostomy, but if they're not thinking the patient's going to come off in pretty short order, they will likely do the tracheostomy. Mechanical ventilation is indicated in cases, again, of respiratory failure, inability to protect the airway, severe hypoxemia, hypercapnia, too much carbon dioxide, and prevention of aspiration, ARDS, pneumonia, COVID-19, COPD, stroke, coma, anaphylaxis, traumatic brain injury, or spinal cord injury. The risks of mechanical ventilation include bacterial infection, lung damage, collapsed lung and heart, and blood flow changes, and prolonging the dying process. Early recognition of these needs is crucial for improving patient outcomes. I'm going to hit this one again here just because there's some yellow on this slide, and I want to make sure that we have a good understanding, or at least that you're familiar with it. Mechanical ventilation is essential in cases of respiratory failure to assist with the breathing and provide adequate oxygenation. Airway protection, the inability to protect your airway indicates the need for mechanical ventilation to prevent aspiration. Severe hypoxemia, and early recognition or identification of the needs for mechanical ventilation significantly impact patient outcomes and the recovery rates.
Question.
Yes, go right ahead.
A patient that's coming in with respiratory failure, you would see obviously a high respiratory rate, probably in the 30s, right? And then they would have like dyspnea. What other symptoms would you see before you go ahead and decide that you're going to put them on mechanical ventilation? Do they have to be unconscious? Do they have to have some type of change in consciousness? Or what warrants them to be on the mechanical ventilation?
Well, a lot of times, I'm going to throw this out there. Does anybody else want to throw in some information about that before I give you more information? Anybody else comfortable sharing?
Mm-hmm.
Go ahead if you are. It's okay. We're all friends here. So not always are patients comatose. They do actually do awake intubations. So you won't always have patients who are comatose. A lot of times you'll see them decline, and sometimes it's rapid. So
So when the O2 stat drops like under, what was it, 70?
well, it may just be that
Or
it's
50?
dropping. So I don't want to give a number necessarily, but obviously if it's starting to fall, there's a problem from a respiratory standpoint. And so they're going to do everything they can to try to prevent mechanical intubation. And that's when their respiratory oxygenation stat starts to drop like that. A lot of times they'll try BiPAP, depending on what the picture looks like of the patient. Sometimes, like I said, they won't be comatose. You'll have a patient that looks pretty good, and then all of a sudden they'll kind of start that downward spiral where, they start to feel a little dyspneic. They might look a little cyanotic. Their lips might turn a little bit blue. They'll feel like they're having a hard time taking deeper breaths. Their respiratory rate jumps up. So they're still alert. They're not necessarily going to be in a coma, although, that's a possibility too, especially if you have somebody come in a trauma situation. So that's kind of, you have to look at the full picture.
Okay.
You
But the
also,
key thing is that O2 stat dropping low. That's the key, right?
that is
Respiratory failure.
one of the key things. Yes.
Okay.
Watching your respiratory rate go up and their oxygenation goes down. And they may have other complaints as well. A lot of times I have had patients say they feel like they can't take a deep breath. And so their breaths appear very shallow. Like they're working really hard, but their breaths are really super shallow. And I'm sure if you've seen anybody actually take shallow breaths, you can kind of picture what I'm talking about there. As far as the respiratory status, but their saturations are key, but I can't really pin a number on it because basically if they're at like say 98% and they start to fall, you're not going to wait till it hits 70% before you do something, right? You're going to jump right in and try to treat the patient before that, correct?
Yes.
Does that answer your question?
Yes, thanks.
You're welcome. Anybody else want to chime in on that? Nope. Okay. So I think we went through this one.
Another question. So you
Yeah,
said,
go
all
ahead.
right. So when their O2 stat begins to go down and their respiration goes up, right? So the first thing you would do is just give them oxygen.
Not
You would
necessarily.
do BiPAP, or you just give them regular oxygen.
Well, what
Can
you're
I help her a little bit? So, like, let's assuming they are on a regular nasal cannula, and then you think they are dropping. So usually the doctor put in an order for a BiPAP. So the BiPAP, when they can't tolerate the BiPAP, and then you see that there is something going on with them, you have to monitor them. So it's not a regular nasal cannula that like usually that's what they do. They put them on different BiPAP. BiPAP is most of what they put them on. When they can't tolerate it, then it means you know that something is going on. Even without the breathing treatment and everything that they give them, you still have to monitor them because they can do emergency, how they call it, right there, like intubate them right there because their lab values and everything is abnormal. So they go according to that. They can still be alert and oriented, but they can hardly breathe. So that's how they do emergency right there to give them to intubate them.
Oh, thank you.
and did you mention, so I think she mentioned the fact that they can do the breathing treatments. So if you have a patient that is starting to kind of start that spiral and you see their numbers are dropping, you're going to have the physician in there. You're going to be calling respiratory therapy because you're going to need a doctor to give you orders. You can't just throw them on BiPAP, so to speak. But they're right. So
Well,
you're
if
going to
you
be
were doing it by an order, right?
right.
Yes, you
The
do it by
symptoms.
an order, but you have to
But we would,
monitor as a nurse. You have to monitor them to let the doctor know what is going on with the patient.
Exactly.
So before you call, you have to make sure that you have all their lab value, you have the
Your
oxygen, their
ABGs.
vitals, everything ready.
Mhm.
Then they will tell you to connect with respiratory, but they have to put an order in for you to put a BiPAP on a patient. You can't just put a BiPAP on the patient. Usually when they start having difficulty in breathing, we can
You're
only put
calling.
2% nasal cannula on them. Then later on, doctors can put in
Mhm.
order for that. But when it goes higher to put a CPAP on, you need a doctor's order before you can do
So if
that.
I
And
understand
respiratory.
you correctly, you're saying like the order would be you give oxygen, then you assess, then you go ahead, and if it's not like if it's worsening, that's when you prepare to intubate them. Then you will call respiratory therapy, and then you call the doctor. That's
Actually,
Right. So when we talk about
Mhm.
intubate, all the team have to be there.
Yes.
As a nurse, we cannot just do intubation without the team. They have to decide if the patient need intubation right away. So sometimes, depending on the hospital policy, they will call
Mhm.
a rapid on the patient. Then everybody come there. So as a nurse, your job is to know the patient, where the patient sat, what the patient needs. So in that case, they will intubate the patient right there at the bedside.
Right. And assess the patient and know when to make that phone call. So as soon as
When to make
you
the
see the
decision.
numbers fall, you're making that.
Mhm.
We always called it well, they called code blues for a long time. Then they changed it to code whites. So as soon as you would see those numbers start to fall and your patient starting to have problems, you're making that phone call, but you're constantly assessing that patient at
Assessing
the
the
bedside.
patient
And then when the team comes, they're actually going to make that decision because part of the
decision.
team is a
Correct.
physician, usually like an ER doc would present at my hospital.
Correct.
And they would say, okay, now we're going to do, we're going to have ABGs drawn. We're going to be doing breathing treatments for this. We might even be giving medication at this point to try to.
EKG stuff.
So all those things are kind of happening at once. So your job as the nurse at the bedside, sure, you can, there's probably a standing order for oxygen in the case of an emergency that you can use a nasal cannula and start it, low.
Mhm.
Once you start that and you start to see things are falling, you're already going to have that team with you, and they're going to be the ones helping make decisions. You're going to be either getting the crash cart or giving the medications or, maybe helping with family or whatever your responsibility happens to be at that time. But up until that point, your job is to make sure you are monitoring the patient and assessing for further decline.
Yeah, and doing vital signs as well. EKG right away, and then they will put in labs as well. You can put hair pluck in, and then you start doing stuff like it's emergency situation. Everybody is helping you too as
Yes.
well.
Yeah,
Yeah,
you're
but
not on your own in these situations.
yeah, it's important for you to know where your patient is. So when a patient is on a respiratory distress, your job is to assess them all the time to know where they are starting, because sometimes the oxygen pulse source is not on them properly and it's not reading well. Your job is to make sure that you are assessing those kind of things so that you know where the patient is at. So whenever there is any danger, you can proper catch it up on time before something happen.
So when you asked earlier if it's just their saturations dropping and if it was like 70, that's why I don't really want to give a number because it's really not just the number. It's
Right.
about the decline that you're witnessing in your patient. So maybe your patient was at, 90% and that's where they breathe at. Not the best number, but maybe they're a COPD patient. And so that's where they live at most of the time. But then all of a sudden you notice it's at 86 and then it's at 84. About that time, if the oxygen is on and they're doing okay, I mean, if it's on and it's functioning okay, there's something more going on. You're going to
Yeah.
call the rapid response team or the code white or the code blue, whatever your hospital considers
Policies.
the respiratory problem or the respiratory call for help. And as this is happening and you make that call or somebody in the room, you yell for help and they make that call, however that happens in your hospital, you're continuing to assess your patient, making sure the oxygen is on. It's
As well.
going to take seconds for your team to arrive and start the full respiratory assessment as far as respiratory treatments or changing it from a cannula to a mask, or, you know, the doctor may come in and look at it and go, nope, we're going right to BiPAP, and it'll happen very quickly. Does that answer the question more so? Hopefully.
Yes. Thank you.
You're
No,
very
you're welcome.
welcome. That is a great question and a great answer. I'm not sure who it was helping answer, but I appreciate all the engaging answers, because it's really helpful, especially if you've experienced, you know, respiratory failure or respiratory decline in your patient. You know what this looks like. It's like imprinted in your brain, and you'll never forget it after the first time it happens, right? Okay. I don't remember if I got through this slide or not, so I'm just going to quick touch on it. Mechanical ventilation is essential in cases of respiratory failure. Inability to protect the airway indicates the need for mechanical ventilation to prevent aspiration. Early identification of the need for mechanical ventilation significantly impacts the patient outcome. This is where our assessment of our patients comes into play. In the big picture, anyway. Okay. Ventilators can operate in different modes, such as assist control, SIMV, which is the synchronized intermittent mandatory ventilation, and pressure support. Understanding these modes can help tailor ventilation strategies to individual patients. Assist control mode allows the ventilator to deliver a set number of breaths where you decide, well, you don't decide. The doctor will decide and tell you where you want it to set. And respiratory therapy, at least in my hospital, was very involved in all of our ventilator patients and helped with the settings. So this is where you deliver a set number of breaths while responding to the patient-initiated breaths. So that allows the patient to have some breaths on their own. That's how we know that they're doing okay as far as being on the ventilator and they're taking their own breaths. Synchronized intermittent mandatory ventilation, SIMV, provides a mix of mandatory and the patient's spontaneous breaths tailored to assist the patient's needs. And then the pressure support mode. Pressure support mode assists patients with spontaneous breaths by providing preset pressure levels during inhalation. And again, these aren't things that I would expect you to know off the top of your head if you're not working in critical care. But just to have an idea that there's 3 different modes and what each of them mean will be helpful to you. Has anybody been in the ICU or worked with any kind of patients who have been on a ventilator and are somewhat familiar with any of these modes? If so,
I
very
work with the
great.
ventilator patients.
What was that?
I said I work with the ventilator patients.
Okay, all right. So
Yeah.
you're familiar with these then,
All right.
right? You see a lot of the synchronized intermittent mandatory ventilation?
All right. And the pressure support and everything.
Yeah, great. Okay. Those are good things to, if you get an opportunity, you work in a hospital and you can go, I know I've said this before, but if you can even go spend 10 minutes with a nurse who has a ventilator patient just to kind of see it firsthand, have them explain to you what setting they're at, it'll help connect the dots in your brain so that when you see it again, it'll make more sense to you. Okay, moving on. We could talk a bit about ventilators for hours and mechanical ventilation, but we have a limited time, so I'm going to keep moving here. Key ventilator settings include tidal volume, PEEP, or positive end expiratory pressure, FiO2, which is fraction of inspired oxygen. There are general principles, and if you work in the ICU, you will learn these well and have respiratory therapy to help support you in the care of your patients. They are very involved in the mechanical ventilation process. So again, some yellow here, so I just want a quick run through them. Tidal volume. Tidal volume refers to the amount of air delivered to the lungs during each ventilator breath. Important to kind of get your grasp around. And PEEP, or positive end expiratory pressure. PEEP helps maintain the alveolar expansion by preventing them from collapsing at the end of expiration. And then the FiO2, which is fraction of inspired oxygen. FiO2 indicates the percentage of oxygen in the air mixture delivered to the patient. Adjusting this parameter is critical for oxygenation. And a lot of times these are monitored by respiratory therapy and obviously your physician, pulmonologists, hospitalists, whoever you have overseeing. We have specialists or intensivists in the ICU that typically monitor this stuff as well, along with the respiratory therapists. Ventilator alarms and troubleshooting. You notice the whole slide is yellow. That's because they're all kind of common things that are just very basic, but things that are important to know in relation to not only your practice, but you may see some questions on your exam about alarms. They're pretty basic alarms, but they're important things to kind of have a handle on. Ventilator alarms are crucial for maintaining patient safety. High pressure alarms could indicate airway obstruction, while low tidal volume alarms may signal disconnection or inadequate patient effort. Troubleshooting involves checking circuit connections and ensuring proper settings are in place. I'm going to quick run through these. Ventilator alarms alert healthcare providers to critical issues. Common alarms include high pressure, which indicates or can indicate airway resistance, and a low tidal volume could indicate a leak in a vent circuit. A low pressure alarm could also indicate an ETT leak or displacement. An apnea alarm could indicate the patient is not taking a breath. Proper troubleshooting is essential for patient safety. Regular checking of equipment and patient connection, and documenting alarm events and interventions taken. A lot of those interventions would include contacting respiratory therapy and perhaps the intensivist if that's what you have on staff at your hospital in your ICU. ARDS. The acute respiratory distress syndrome results from severe lung inflammation leading to impaired gas exchange. Patients exhibit rapid breathing and may experience low oxygen saturation levels. Treatment primarily involves providing adequate oxygenation through mechanical ventilation, monitoring fluid management. Less is more here. We have to be really careful with fluids. Positioning in a prone position can help improve oxygenation and survival rates. Enteral feeding and addressing the underlying cause. Nurses play a vital role in monitoring patient status, administering medications, and ensuring patient comfort during this critical phase. I also like to throw out that patients who suffer from ARDS, if there's family around, it can be very scary, the things that we're doing, especially if we're putting a patient in a prone position. Make sure that we're supporting the family and explaining everything that we're doing, all the interventions to help improve the patient's survival. ARDS is characterized by severe inflammation in the lungs. Its symptoms include rapid breathing, coughing, chest discomfort, fast heart rate, and severe shortness of breath. They're typically called hallmark symptoms of ARDS. Common causes include pneumonia, sepsis, and trauma. Treatment focuses on oxygen support, fluid management, very important. Less is more. Putting a patient in the prone position, enteral feeding, and addressing their underlying causes. Nursing interventions include monitoring their vitals and providing comfort. Weaning and extubation require careful assessment of the patient's respiratory stability. Successful trials indicate the patient can breathe independently. Key factors include the patient's mental status, airway protection, and the absence of respiratory fatigue. Other weaning modes include non-invasive positive pressure, adaptive support ventilation, and the automated mode. Proportional assist ventilation and neurally assisted ventilator, adjusted ventilator, where neural signs can trigger breaths. Most or many ICU weaning protocols include the daily SBTs, which is this successful breathing trials. This is probably the most common indicator for readiness for extubation. It just depends on your hospital and what your protocols are, but this is what I've seen the most of. Assessing mental status and airway protection is crucial, and monitoring for signs of respiratory fatigue during the process. Unfortunately, a lot of times people get extubated and end up back on mechanical ventilation. A lot of times they don't, but sometimes they do. Post-extubation care includes frequent assessments and support. Tracheostomy care essentials. Trach care is vital for preventing complications and ensuring airway patency. Regular suctioning helps clear suction secretions, and monitoring the stoma is essential for identifying infections. Education for patient and families ensures that they understand how to care for it effectively. It's also important to have emergency equipment on hand in case of a tracheostomy-related emergency. Regular care prevents infections and maintains airway patency. Suction is required to clear secretions. And the other thing I think is important is making sure there's emergency equipment at the bedside. So emergency equipment might be trach tubes of various sizes, specifically the current size, and usually a smaller one in case you have some kind of swelling or something in there, or edema present that they may have to use a smaller tube. A bag mask valve for the stoma, trach mask, suction cath, wall suction or Yankauer suction, and an occlusive dressing. Those are just the basic typical things that you can find in an emergency equipment kit, but you will generally find them in the rooms of anybody who has a tracheostomy. Anybody have any experience with that or seeing those in your patient rooms, especially those of you who are working with patients who are ventilated? All right, here we go. Chest tube drainage systems are critical for managing pleural abnormalities such as pneumothorax and pleural effusion. The chest tube is inserted into the pleural space to drain air, blood, or fluid, allowing the lungs to re-expand. They can be set to a wet seal, where the water is used to create suction, or dry, which is controlled by wall suction. Nurses play a key role in monitoring the system for proper function and assessing the patient for any complications. Monitoring insertion site for infection, keeping tubing free of kinks and obstructions, like stepping on it or having it get caught on the bed rails as they go up and down. Monitoring chambers for proper functioning of water seal, which is called titling. I have that on here. Monitor chamber for proper functioning of water seal, which is called titling, and that's normal. That's a normal finding. And suction control of the control chamber, which is called bubbling. Monitor suction control chamber for bubbling. Documentation of drainage output, the color and the consistency, along with the patient's response, which is essential for ongoing care and evaluation. Anybody have any experience with chest tube drainage systems, especially to the water seal? Those seem to be the most common from what I've seen. A quick check the that prone position is related to ARDS and patient survival. In prone position, they find that patients survive better if they experience ARDS. That's right. Oh, somebody answered. Good job there. It is with ARDS. I'd be curious to know if I know in our hospital I've seen it done. I don't know if perhaps in your hospital, if you've seen that done, go ahead and give me a shout out. And in your hospitals, you're seeing hemothorax and pneumothorax. Yep. Yep. Great. The Pneumovac, I think, is the one that, I think that might be what this one's called. The Pneumovac, I think that was the name of our chest tube drainage system. It always amazed me that when patients would try to get up and go to the bathroom, they would forget about their Pleuric system, and you're quick grabbing it so it doesn't get caught and kinked up in the bed rails. It can be kind of scary that first couple of times you're working with those drainage systems. So, all right. I did want to I mentioned the titling and the bubbling. Those are normal findings, and those are things that are helpful for you to remember. You may see them in your NCLEX testing, and you may see them in conversation when you're evaluating your patient or making an assessment of your patients if you happen to have a patient with chest tube drainage system. I'm going to quick review these just to make sure we don't miss anything here. Chest tubes are used to drain air or fluid from the pleural space. Indications include pneumothorax, pleural effusion, and hemothorax, as somebody mentioned in the chat. Thank you. Monitoring for complications like infection or tube dislodgement is crucial. A lot of times patients, assuming that they're alert, will let you know if their tube becomes dislodged. Monitoring the chamber for the proper functioning of the water seal, which is called titling, and if it's monitoring suction controlled chamber for bubbling. Nursing interventions focus on ensuring proper function and patient comfort, and documenting the output and the patient status is essential. How are they responding to the fact that they have these chest tubes in? Okay. I think I covered the part that I thought was the most important here, and that's knowing about titling and bubbling. Wow, we got through that pretty quick. So, strategies for success on NCLEX. Preparing for NCLEX requires a strategic approach. Process of elimination, Maslow's hierarchy of needs, nursing process, and applying the true and false method. If you've seen my other webinars, I pretty much always just mention these strategies just to help kind of reiterate that they're important when you're answering questions. Process of elimination narrows down the answer, focuses on eliminating wrong answers and obviously wrong answers, and then it leaves the remaining choices to find the best answer. Maslow's hierarchy of needs, understanding the needs based on Maslow's theory. Safety comes first, safety, secure, or physiologic safety, security, and then psych-social needs. Airway, breathing, circulation. I almost always approach questions with this first. Sometimes it doesn't apply, but then it kind of rules it out in my mind. Okay, we moved on to maybe safety or security, and then to psych-social. Prioritization strategies, identify urgent versus non-urgent, use frameworks to categorize patient needs, and definitely apply prioritization in clinical scenarios. Nursing process. The thing about nursing process, when I see something in a question that says the patient admitted with suspected or to the ER, patient in the ER with suspected. When I see the word suspected, my mind immediately goes to nursing process because that means potentially, what is nursing process all about? Assessment. We might need more assessment before we can provide an intervention. That's what nursing process is. We do assessing before we do any kind of intervening. Okay, understanding key concepts in respiratory care is crucial. This is kind of my, the slide that just kind of closes up gives us closure to the respiratory key concepts. Understanding key concepts in respiratory care is crucial for effective clinical practice. Familiarity with terminology like the bubbling and the titling and the ARDS helps provide communication. It enhances communication among healthcare professionals, and it improves patient care, and it improves patient survival, especially in like ARDS. A solid understanding of respiratory care concepts contributes to success in NCLEX. All right, I know you've heard me say this 1,000 times, but I'm going to say it one more time. Practice, practice, practice makes perfect. Regularly practicing NCLEX style questions will help make your exam easier for you. Using a test taking strategy, make sure you're managing your time. Try to reduce your anxiety, will improve your performance on your exam. I know it's stressful, so try to get a handle on your anxiety, come up with a coping mechanism that works for you, but make time to practice. And be confident. I keep telling you, you all got here for a reason. You all graduated from school. You're sharp, you're smart, you're here because you're going to embrace this wonderful career. But you got here because you are intelligent and you can do this. You have the capability, you have the knowledge. It's just applying it the right way to the questions. And we pretty much covered the conclusion already, so I'm going to skip that and move right into our questions here. Okay. Does anybody want to read a question?
Yes.
Go ahead, please.
A client with a tracheostomy tube in situ is admitted in a medical surgical unit. As the nurse is passing by, she hears a gurgling sound from the client's tracheostomy. Which is the nurse's priority intervention? A. Inflate the tracheostomy curve, prop up the client, notify the healthcare provider, assemble items for suctioning.
All right, we can give it a minute here and then see if anybody wants to, if you would like to answer the question, you certainly may. If you want to let somebody else do it, that's okay too. Whatever you are comfortable with. And thank you for reading the question. I just want to point out that this one does ask about a priority intervention. So we know it's a prioritization question. Anybody want to answer? So in this question, the answer would be assemble items for suctioning. It is D. And it is D because we're hearing gurgling. So gurgling from a trach tube suggests that secretions are obstructing the airway. Suctioning is a priority intervention for that to restore airway patency and prevent complications like hypoxia and aspiration. So why would the other ones be incorrect? I think it's important to always look at all the rationales. So if you don't mind, I'm going to go ahead and go through those as well. Inflating the tracheostomy cuff, gurgling likely indicates secretions in the airway, requiring suctioning first. Inflating the cuff without addressing the secretions could potentially worsen the obstruction. So that's why we would not inflate the tracheostomy cuff. Prop up the client. Elevating the head of the bed could help improve the airway by causing drainage to run down, facilitating breathing. However, in this scenario, it would not directly address the already gurgling patient because we already know the gurgling indicates there are secretions that need to be suctioned. So that's why propping up the client would not be correct. And notifying the healthcare provider, I will say most of the time it is not the correct answer, but in this case, it's not the correct answer because what are they going to ask you to do? They're going to say, what did you do about it? Right? What did you do about it? Well, I called you. Well, that's not the right answer. You need to suction first. So that's why it wouldn't be correct.
Yeah.
All right. Good job reading the question. Does anybody want to read the next one?
Yeah.
Okay, here we go.
A nurse is caring for a client whose tracheostomy has dislodged 7 days post-operatively. The client in respiratory distress. What is the nurse's priority action? Call for immediate medical assistance. Apply an oxygen mask over the stoma. Replace the tracheostomy tube. Use a bag-marked ventilation to oxygenate the client.
So that was part of our emergency trach kit at the bedside. That might give away the answer. I do want to just point out it is a priority question. So what are we going to do first? There's probably more than one right answer here of actions that we should do, but one is the most right and the thing we should do first. That's going to address the patient's dislodged trach. So if anybody wants to answer it, we can give it a couple of seconds. So the correct,
C.
go ahead, please,
Replace
go
the
ahead.
tracheostomy tube.
I'm sorry?
C. Replace the tracheostomy tube.
So in this particular instance, actually,
Nurses don't replace anything.
you guys are sharp.
Yeah.
Is D.
Yeah, I
Yeah.
think it's D. Because it says like the client is in respiratory distress. So if we're following ABC,
Mhm.
we'll probably like address that first. So we probably want to, oxygenate the patient and then probably call for immediate assistance
And so how are we going to oxygenate the patient?
with a bag mask.
Yes, excellent. You guys are sharp. So D, yes, absolutely. The bag mask ventilation to oxygenate the client. The priority is to ensure the client is adequately oxygenated. The bag mask ventilation is the quickest way to achieve that and prevent hypoxia until the trach tube can safely be replaced. So A, call the medical provider. What are they going to tell you? What did you do, right? So they're going to want more information so that although it is crucial to call them because of this happening, it's not the first thing that you're going to do. Perhaps somebody else could be doing that while you're doing the bag mask ventilation or vice versa. B, apply an oxygen mask over the stoma. While this can help temporarily, it is not the best immediate action for adequate ventilation. So that's why B is not correct. And C, replacing the tube. Although replacing the tube could help reestablish the airway, it is recommended that a physician perform the reinsertion, particularly if it is the first time since the tracheostomy was performed. So that's why we would not do that either. And D was the correct answer here. So good job. All right. Anybody want to read number 3?
A nurse is caring for a client who is on mechanical ventilation. The nurse notes that the ventilator alarm has been triggered 4 times and that the ventilator rate and the client's spontaneous breathing rate are not matching. What is the priority intervention for the nurse to take? Check the ventilator settings and ensure they are correctly set. Humidify the saline and suction to remove secretion. Reassess the client's oxygen saturation and arterial blood gases. Notify the healthcare provider immediately.
Thank you very much. Excellent job. It's another priority question. What is the priority intervention for the nurse to take? So that tells me there's probably more than one thing we should be doing, but one is the most important. If anybody wants to go ahead and take a stab at this one. So if we have a patient on a,
Check the ventilator settings and ensure they are correctly set.
good job. You guys are so sharp. Yes, that's the correct answer. It is A, to check the ventilator settings and ensure that they are correct. Basically, we're doing an assessment here. Make sure that this is right because we can't really do any of the other things until we've checked the ventilator settings. It kind of reminds me of, not that they're all the same thing, but when your computer stops working and you go, what the heck? What's the first thing you check for? The power source, right? You always go to the power source first. So I know they're not the same thing, but it kind of reminds me of that. Before you do anything else, you check that. Okay, so A, checking the ventilator settings is the correct answer. When a ventilator alarm is triggered multiple times and there is a mismatch between the ventilator rate and the client's spontaneous rate, it's crucial to assess and confirm the ventilator settings. What about B? So why would we not do B? While suctioning and humidifying are important interventions, the option is secondary to the scenario. And C, reassess the client's oxygenation, saturation, and ABGs. The mismatch in ventilator rates and alarm activation success suggests a problem with the ventilator or the settings. And D, calling the healthcare provider, the nurse should first address the mechanical issue by checking the ventilator settings first, because that's going to be the first thing that your healthcare provider is going to ask you, what did you do about it? And you need to have the answer for that. Okay. Any questions about that one? You guys did a great job.
I have a question.
Okay, about that one?
Yes.
Okay, let me go.
Someone did put in the chat, and it's if one of the answers was check the patient first, you know, something with, you know, inspect that the patient is on, there's no problem with the patient, would that be the answer, or still check the settings first?
Well, I think it's very, how shall I say this? It's really important to read the question, but not read into the question.
Okay.
So because this particular question indicates that the ventilator alarm has been triggered 4 times, I still think the answer is to check your ventilator settings, because the alarm is being triggered here, right? And that the ventilator rate and the spontaneous breathing are not matching. So what would you check for the patient? Because they're already on a ventilator, right? And they're already having the spontaneous breathing. So it's likely that it's the ventilator settings or the ventilator that is the problem, and it may not necessarily be the patient. So I still feel like this would be the correct answer, even if check the patient were an option here.
Okay.
That would be my thought, and I would feel that way because of the fact that it's talking about ventilator alarm being triggered. Now, if it didn't say that, if it didn't tell me that the alarm's been going off 4 times, I might feel differently about that.
Perfect. Thank you.
Yeah, and
You're-
also in the question mentioned that the client has spontaneous breathing rate that is not matching already. They've already seen the breathing rate of the patient, so it has already been assessed.
Mhm. Yeah, that they're having spontaneous breathing.
There's no point checking the patient again. It has been mentioned in the question.
Mm-hmm. Okay. Does that answer the question?
Yes. Thank you so
Okay.
much.
You're welcome. I have my talking thing slid over, so I can't see necessarily who's asking me the question. Otherwise, it covers up my slide. So thank you for that question. Okay, I'm going to go ahead and go to number 4. Anybody would like to read this?
A
A
home
home,
health. Okay.
a home health nurse is visiting a client who has a tracheostomy tube. It will require intervention by the nurse if the caregiver is observed. A, using clean technique instead of sterile technique when changing the inner cannula. B, applying suction during the insertion of the catheter while suctioning the tracheostomy tube. C, adjusting loop and hook fasteners to hold the tracheostomy tube in place. D, removing oral secretions from the same catheter that was used for suctioning the tracheostomy.
Thank you. Good job. Excellent job reading that. I'll give you guys a little bit to answer. Okay. Anybody want to take a guess at this one before I answer?
Yeah.
I think it's a big correct answer.
B?
Yes, it could be
That's-
wrong.
No, you are not wrong. You are correct. B is the correct answer. Applying suction during the insertion of the catheter while suctioning the trach.
The tracheotomy tube. First of all, A, I'm excluding
A is what?
because when we even changing inner cannula, the technique is supposed to be sterile. Instead of the clean, it's supposed to be sterile.
Okay. For the inner cannula. And we have to remember here in the question,
It's a home, and at home we are not changing inner cannula.
exactly. And also at home, a lot of times we don't do things that are sterile because at their home,
It's
their
not
home,
sterile technique. We can save the sterile
exactly. So
technique.
B
We
is
can afford
correct.
the sterile
Good-
technique
yeah.
all the time. And we
Mhm.
are not changing at home in cannula.
Correct. So B is the correct answer. Applying suction during the insertion of the catheter while suctioning the trach tube. Suction should be applied only during catheter withdrawal, not during insertion. Let's see. I wanted to talk about give me 1 second. There was something I wanted to
And
make
oral
sure I shared with you.
secretion, yes. And oral secretion, I think we are not using the same catheter.
Mm-hmm. Oh, yes, that's correct. And then clean technique instead of sterile technique at home, because this is a home health nurse. So this patient is at home and we don't do sterile technique at home. We do clean technique, if that makes sense to everybody. Removing,
But I have a question.
yeah, go ahead.
But isn't this question asking for a wrong answer? So wouldn't it be D? Because it says it requires intervention by the nurse.
No, it's not looking for the wrong answer. It's
It would require intervention by the nurse if the caregiver is observed.
applying suction during the insertion of the catheter while
Oh,
suctioning.
so they're not
It's a
suctioning.
wrong thing
Right.
to it's a wrong thing to sanction while inserting catheter. It's when you're removing or
I
withdrawing
can't
the
hear. I'm
catheter
sorry.
you sanction. So
Right.
and that's why it's an intervention the nurse should
It's like a double negative, if you will.
yeah.
These questions make me a little on the crazy side, just because you have to like really like think them through and kind of think if you're going to do true and false, like you're looking for the false action as opposed to the true statement. So these are a little bit tricky, and you really have to keep in mind now we're at home with the patient. Is that a distractor? Is that part of the answer? So they can be a little bit tricky. So good catch there, though. It would
To be
require,
honest with you, I start thinking about method exclusion, which I can exclude it first. First of all, I think at home we can do the sterile technique.
right?
How I exclude the A. D, I exclude because we are not doing removing oral secretion and suctioning from the tracheostom the same time.
Mm-hmm.
I said that's a two exclusion, and between B and C and adjusting loop and loop head faster, that's not working how the tube is placed at the home.
Yeah, that's a great way to do it. That's a great way to,
That's why I'm thinking about the B.
that process of elimination worked great for that, right?
Yes, that's why I'm saying eliminate. First one.
So I just want a quick look at the rationales here and kind of share them with you so that it kind of makes a little bit more sense. All right. So B is correct because applying suction during the insertion of the catheter while suctioning the tracheostomy tube. Suction should be applied only during catheter withdrawal, not during insertion. Okay, so that's the here, insertion, so that's why it would be incorrect. Applying suction while inserting the catheter can cause mucosal trauma, hypoxia, vagal stimulation, and lead to bradycardia. And now let's look at A. Using clean technique instead of sterile technique when changing the inner cannula. In the home setting, we use clean technique, not sterile technique. So that's why that one is incorrect. C, adjusting the loop and hook fasteners. Using Velcro hook and loop fasteners or tracheostomy ties to secure the tube in place is the correct practice. Proper fastening prevents tube displacement, which obviously can be life-threatening, especially at home. And then D, remove oral suctions with the same catheter that was used for suctioning the trach. The same catheter can be used to remove oral secretions after suctioning the trach if needed. If the suction catheter is to be reused, place it in a container or distilled cup of sterile water. Apply suction for approximately 30 seconds to clear the secretions from the inside of the catheter. So does that help answer that one?
Yes, yes, thank
Okay.
you.
You're welcome. Thank you for reading and answering. You guys are really sharp. All right, number 5.
A client has a chest tube connected to the water seal chamber. The client is breathing comfortably with no fluctuation of fluid within the chest tube and water seal chamber. Which of the following is the most likely interpretation of this observation? The lung has fully re-expanded, the lung has collapsed, the chest tube is correctly positioned in the pleural space, the chest tube is blocked or kinked.
Okay. So remember
Yes.
when we talked about titling and bubbling in the drainage system? So if we see no fluctuation in the fluid within the chest tube and the water sealed chamber, which would be titling, which of the most likely is the most likely interpretation? The answer is A.
I think it's a D.
Yeah. Sorry.
The answer is A. The lungs has fully re-expanded.
Yes, that is correct. The lung has re-expanded. Titling in the chest tube refers to the movement within the water sealed chamber. The lung has re-expanded, and as it re-expands, air and fluid are no longer being drawn into the pleural space. So excellent job there, you guys. Sorry, I kind of jumped the gun on that one.
Could you explain again? I don't understand that.
So if you go back to when we were talking about the chest tube drainage system,
Yeah,
so a normal finding when you have somebody hooked up to a water seal chest tube drainage system, not to the wall, but to the one with the water seal that sits kind of on the floor, it has titling, which is like almost like that bubbling fluctuation that you see in the water. That tells you that you have a water seal, that the patient is breathing comfortably, and when they breathe, it sort of does this, they call it titling, but to me, it's almost like bubbling. And that's a normal finding. So if you have a patient and you don't see that any longer, okay, the client's connected to the chest tube and they have a water sealed chamber, so you know it's the one on the floor, it's not the one hooked up to the wall. The client's breathing comfortably with no fluctuation in the fluid within the chest tube and the water sealed chamber. So which of these is the most likely answer? Well, when they start to improve and their lung starts to reinflate or re-expand, that stops the fluctuation or the titling, whatever you want to call it. So that's why this is the right answer. So does that help? I'll go through why the other 3 are wrong, and that might also help.
Okay, so in titling, you want fluctuations.
Yes, exactly. That's a normal
That's
finding.
normal findings, yeah.
Okay. And then since the patient is not having fluctuations, that means that their lungs are completely expanded. So now they don't need the chest tube, right? Perfect. I got it.
Bingo. So in a lung collapse, let's look at why B, C, and D are wrong. In a lung collapse, the client would exhibit signs of respiratory distress, right? And this question does not indicate that at all. Now, if it would have indicated that, obviously A would not be the right answer, right? If they were having shortness of breath and breathing difficulty. Additionally, there could be other signs such as bubbling in the water sealed chamber indicating an air leak. Which this does not talk about either. So C, let me see, the chest tube correctly positioned in the pleural space. Why is that not right? Because proper positioning is essential for drainage. The absence of fluctuation does not confirm that the chest tube is correctly positioned, okay? And then D, the chest tube is blocked or kinked. That would not be correct because if the chest tube were blocked or kinked, it would indeed stop fluctuation. But in this case, the patient is breathing comfortably. I think that's the other key to this question here, is that they tell you the patient's breathing comfortably with no fluctuation. If they said the client was short of breath, obviously this would not be the right answer. It could be this, it could be this, or it could be this. They'd have to give you a little.
I'm sorry.
Go ahead, don't be sorry. Share.
If I just want to give the other way. If the client not comfortable in this situation and we see no fluctuation on the fluid, it will be checked to blocked, yeah, or not. Is that correct?
You would want to be checking to see if there were a block or a kink, yes?
Yes, if it's patient not comfortable breathing.
Right. Yeah, this is the key right here.
That's why I'm saying the key here
Yeah,
is breathing comfortable. If it's patient uncomfortable breathing, the right result, the right answer, it will be D. Yeah.
Yes. Well, potentially. I mean, I'm assuming if they wanted you to pick D, that they would probably not add any other information, but that would be up to the content writer.
Yes,
but
here is a key point as a priority is breathing comfortable. From that, we can make a decision which is the right answer.
Exactly.
Thank you. Oh my
So,
God, this is hard.
I
This
know. I
This
know.
is hard.
And it's so easy to read things into these questions.
One word is changing whole result.
Yeah. So just remember that, take a deep breath
and read question twice.
Read the questions twice and try really hard not to read into them, because you're going to look at it and go, oh, I know what it is. And if you don't read it twice, you skipped the whole point that the client was breathing comfortably, right? So that's why you didn't assume that the lung had re-expanded. You assumed there is something wrong with the drainage system, or perhaps their lung had collapsed, because you kind of overlooked the fact that the client was breathing comfortably. If they had some kind of respiratory issue, they are not going to be breathing comfortably, especially if their lung collapsed, or if there's a kink or something blocking their tube. They're not going to be breathing well. You're welcome. Don't overthink it.
I know.
Just keep practicing. And the fact that this happened and that we're still talking about it is going to remind you all, if you run into this question on your NCLEX, you're going to go, I remember this.
Yes, true.
Breathing fine. And so the lung has re-expanded, right? So it's good to share this way.
Yep.
All right.
Yeah.
I hate to say we got to speed it up, but we do have to speed it up because I have to be off of the platform very quickly here.
A client accidentally pulls out their chest tube. What is the nurse's priority intervention? Apply a sterile occlusive dressing over the site. Notify the healthcare provider.
Apply sterile occlusive dressing. A.
Let me finish. The right answer might be down. Let me finish. Monitor the vital signs. Ask the client to perform maximum expiration.
Okay, so what's the answer?
A. This one is easy.
It is. It's apply a sterile occlusive dressing over the site. That is the priority intervention here. And I'm sure everybody knows why this is an immediate priority, because it helps seal the site, right? Prevents air from entering this space, creating
embolism, yeah.
Right?
Helps, yeah.
Okay, so then B, C, and D, let's briefly talk about why those are wrong. B is wrong because notifying the healthcare provider is crucial for further management, but it should not happen until after you take the measures to prevent the pneumothorax, because what's their first question going to be to you? What did you do about it, right? And we never want the physician saying that to us. What did you do about it? And you have to go, I called you first. Monitoring vital signs indicate the client's respiratory status, but they do not address the problem, which is the fact that their chest tube came out, right? So we need to address that problem before anything else. And then ask the client to perform maximum expiration. Focus should be on sealing the site to prevent any kind of further complications, i.e. a pneumothorax. All right, good job, guys. Question number 7. Anybody want to have at it?
A nurse is caring for 4 clients. with closed chest tube drainage system. Which client should the nurse assess first? A client who has tidalin in the water seal chamber and a small amount of crepitus around the insertion site. A client who has thoracotomy 1 day ago and has a chest tube output of 100 ml in the past 2 hours. A client who has a continuous bubbling in the water seal chamber and respiratory rate of 36 per minute, or a client who has a chest tube placed 1 hour ago and reports moderate pain at the insertion site. Who should they not see first?
Priority question. Yikes. So we talked about titling being a normal thing, right? But not about crepitus.
I think
I said C.
C, because it can continue bubbling in the water chamber. It's supposed to be intermediate bubbling.
Very good. You guys are so sharp. It is C. C is the correct answer here. And it is correct because continuous bubbling in the water sealed chamber indicates an air leak, which could suggest a pneumothorax or a leak in the system. The presence of tachypnea indicates respiratory distress, making the situation even more of an emergency
Right,
and requires
37 per minute, yeah.
Requires more immediate of an assessment and intervention to prevent respiratory compromise. A, the patient who has titling in the water seal and small amounts of crepitus around the insertion site. Titling fluctuations in the water is a normal finding, which we've talked about. Small amounts of crepitus, which is like subcutaneous emphysema, if you will, are common after chest tube insertion, especially and usually resolve without
I'm
intervention.
so sorry. Crepitus around the insertion shaft. That's not complication, yeah?
Now,
Major complication.
it is not complication if it is mild and if it is a round insertion site
That's okay.
and if it resolves.
Oh,
It
okay.
should resolve. It should spontaneously resolve without intervention. If it doesn't resolve, you could have some sort of issue. But it should resolve on its own spontaneously.
Okay.
Okay.
But if it's small and resolve by themselves, that's okay.
Okay.
Thank you.
Say
Okay,
crepitus
sorry,
was?
I want to ask, like, how long does it take to resolve?
Couple minutes, maybe.
That's a really good question. I would say it doesn't take very long, but I can't give you a specific time frame. Maybe if Hermonies could look that up and kind of give us a range of when crepitus should resolve and how quickly after having a chest tube placed it should resolve and how long we should see it. That would probably be some good information to have. Good question. We'll get you the answer for that. I'm going to have my nurse managing the chat answer that question for you. So keep an eye on the chat, and then I'm going to keep going here because I want to get
I have
to.
a question real quick.
Yeah,
Is
go
it the same crepitus like with the knees, or is this a different crepitus, like the cracking? Like, you know how when your knees crack, it's crepitus. So
No,
in
it's
terms of the
different.
water seal, what does that mean?
It's a little bit different than that. And honestly, the first time you hear it or feel it, it's what is it? It reminds me of, I want to say, the bubble wrap that you pop.
Mm-hmm.
That's what I think of.
So when you feel where the chest tube is, you feel like
Around it. So if
around it, it feels like little
around
bumps.
that area.
Okay, at least that's a mental image.
Yeah. So they have bubble wrap around their insertion, right?
Yeah.
Okay. D, did I cover?
Bubble wraps are harmless, so
Yeah, we
I
did.
remember that.
That was the right answer. So D, a client who has a chest tube placed 1 hour ago and reports moderate pain at the insertion site. Moderate pain is definitely expected after chest tube insertion. While pain management is important, it does not indicate an emergency situation. And yes, they are uncomfortable. Okay, now everybody take a deep breath. This is not as scary as it looks, I promise. Okay. A nurse is monitoring the client. Match the following ventilator alarms to their most likely causes. Obviously, we can't drag and drop, so let's just go through them and you guys can read them, and then I'll ask you and you can tell me which ones, which ventilator alarm goes with which cause. Does that make sense? Does everybody understand what we're doing?
Yes.
Okay. So we did cover these. They're in one of my yellow slides. Of course, I don't expect you to remember all of that right off the cuff.
Mm-hmm.
But high pressure alarm, what would that be indicative of?
Increase airway resistance.
Increased airway resistance.
God, you guys are sharp. Low pressure alarm.
Displacement.
And ET cuff leak or displacement. Very good. Low tidal alarm.
Leak.
Very good. And then the apnea alarm.
They're not breathing.
Very good.
Not inhaled, right?
All right.
Hold on 1 second. Let me just. Perfect. Thank
Got
you.
it?
Yeah, I got it.
You're welcome. And again, remember, you guys can pull these, this presentation and any other presentation at the end. Once we're done, they'll be available on the website in case you missed something. So number 9. Anybody want to read it?
A client with pneumonia has been prescribed high-flow oxygen therapy. Which of the following devices is the most appropriate? A nasal cannula, non-breather mask, Venturi mask, or a simple face mask? A client with pneumonia has been prescribed high-flow oxygen therapy. Which of the following? So they're getting high-flow oxygen.
So that means it's probably greater than 6. So we
Right.
can
So
rule
you
one
can't
out.
give it in a nasal cannula because I think nasal cannula goes up to 2.
6.
Oh, it does go to 6.
Six, yeah.
It goes to 6.
Yeah.
So we can eliminate that one.
And simple face mask is a very quick and a large amount, and for pneumonia we want to
It's
keep
big,
longer.
thing. Isn't Venturi?
I think the Ventura mask is a
Yeah,
high
the
flow.
Venturi. Because I think it goes up to 10, right? I might be wrong.
More.
60, I think.
How much?
The Venturi goes to from 24 to 60% FiO2. And it's usually
10 to 20.
Hold on 1
Yeah.
second. What's she saying?
They go by percentage in our rationale, so it's higher than that. So it's like 10 to 20 or 24% to 60%. So we know it's not nasal cannula. And what about the simple mask? That
No.
one goes 5 to 10. Right? So which one do you think it is?
Mask.
I think it's a C.
C or B?
B.
B?
Non-breathing.
Because the highest flow, it's a Ventura mask, yeah?
No, but she's
that
saying
wrong?
that it goes by percentage. So
Well,
therefore,
here, let me break it down for you. So we eliminated nasal cannula, right? Because we know that that's not a high flow. So that leaves us with the other 3. So the answer is B, and I'm going to tell you why. So the nasal cannula, I'm going to go through all of them though, just so that you can understand it. The nasal cannula provides low to moderate levels of oxygen ranging from 1 to 6 liters, okay? Which is delivering about 24 to 40% oxygen, or FiO2, which is the percent of oxygen that's actually delivered. The Venturi mask is known for its ability to deliver precise and consistent oxygen concentrations ranging from 24 to 60%. It is not suitable for clients needing high flow. Oh, excuse me on that. It's not suitable for clients needing high flow oxygen, relates to the nasal cannula. The Venturi is typically used for clients who require specific and controlled concentration, such as those with like COPD, where you can't go high on their oxygenation rate because of their COPD. So that's what the Venturi is used for. It's a very specific range or percentage that you can give with the Venturi. The simple face mask provides 5 to 10 liters of oxygen, which goes from 40 to 60% FiO2, which is the amount of oxygen delivered. While it provides more oxygen than the nasal cannula, it does not deliver as high of an oxygenation concentration as the non-rebreather mask. Okay? Does that help? So the non-rebreather mask,
The simple face mask is just for low oxygen, right?
5 to 10 liters. So I don't want to say low because nasal cannula is 1 to 6. Simple face mask is 5 to 10. So it's not the high flow. It's the
Moderate.
5 to 10. Yeah, moderate. I mean, they only go by high and low, but
Okay.
and technically low flow is 1 to 6. Okay. So did we cover all 4 of them? We did get the answer is B, right? It's ideal for the non-rebreather mask. I don't think I read that one to you. The non-rebreather mask is ideal for providing high concentrations of oxygen, delivering, here's the difference. I did not read this one to you, so it's very important. 95 to 100% FiO2, and the rates are 10 to 15 liters. So it has the ability to provide 100% oxygen, ensuring that the high concentration oxygen is delivered to the patient who needs it. So the non-rebreather mask is why it's considered the high flow, and it's why it's the most appropriate device for this
Yeah.
patient.
Hello, please. I'm sorry for cutting you short, please. If the ventral mask delivers 40 to 60% of oxygen flow, so what is going to be the liter per minute?
So the simple, are you talking the 40 to 60
The
is 5 to
yeah.
10. It's 5 to 10. It's a range.
Okay.
So it's 5 to
Okay.
10. And then, but the important part about this one, the non-rebreather that I wanted to make sure you understand is that it can deliver 95 to 100% oxygen at 10 to 15 liters. Okay. So that's the
Okay.
difference here. 1 to
Yeah, thank you
6,
so much.
10 to 15, and then the simple face mask was 5 to 10 also.
Okay.
Okay. And then the Venturi
Yeah.
has the ability to deliver a very specific amount as opposed to a range for people who have like COPD. I know it's a little
Thank you.
difficult to understand, but it does make sense if you look at it that way. All right, number 10. Somebody want to read that one? You guys are so good at this.
A nurse is caring for multiple clients in respiratory distress. Which of the following conditions are indications for initiating mechanical ventilation? Acute respiratory failure with a PaO2 of 48, supplement oxygen, despite supplement oxygen. Okay. Respiratory acidosis of pH of 7.28 and PaCO2 of 55. Okay. What's that? Myasthenia gravis, crisis with severe respiratory muscle weakness. Chronic obstructive pulmonary disease, COPD, with a POCO2 of 50 and a pH of 7.36, and pulmonary edema with SpO2 of 91 on room.